Thank you for the invitation. It's a pleasure to talk today about some of the work we've been doing. Firstly, a couple of words about the Pain Management Research Institute, of which Paul is the director. The PMRI has been part of Collins since its inception about 25 years ago. Our mission is consistent with some of the earlier ones we've heard today, to be a global leader in developing comprehensive solutions for chronic pain. That's pain that persists beyond 3 months and can last a lifetime. And we also are very focused on teaching other health professionals how to deliver better solutions for chronic pain. We do both lab-based research, and Karen Aubrey will talk about that in a minute, or later this morning, and clinical research at the Douglas Building. In clinical settings, pain is usually related to injury, sometimes, and of course diseases, as well as distress and disability. So pain never occurs in a vacuum. Today, I'm going to present some of our recent research on pain self-management in injured workers to prevent disability, reduce distress, and obviously get people back to work. The key point I'm going to be making, again, consistent with some of the philosophy we've heard today about translational research, or I guess I often use the term implementation research, which is actually implementing the findings of research. The key point here is in early intervention with injured workers, the focus should be more on the management strategy used rather than specific treatments. And I'll come back to that. So the background story to this research is that in 2012-13, New South Wales Ministry of Health, Workers' Compensation was rapidly deteriorating with an increased rise in the cost to New South Wales Health. A key reason for the increase in costs, which of course meant there was less money to spend on health care generally, was the increase in length of time the injured health workers were away from work. Now, 6 years later, iCare, which replaced WorkCover, reported in 2019, basically there'd been no improvement in their outcomes. The delayed return to work over the previous 5 years was getting worse, and there were more and more people taking more than 90 days off from an injury before they could get back to work. The CIRA, the State Insurance Regulatory Authority, asked Janet Dorr to make a report about what was going on, why weren't things improving, and she published this in 2019 with CIRA. And what she noted was an inability by iCare to identify those at risk of delayed return to work. Another review by CIRA last year found major problems in the way injured workers were being managed in New South Wales. There were delays in treatment and overservicing. What is meant by overservicing is basically excessive amounts of treatment that fall outside the typical treatment patterns for a condition. My argument in this presentation is that both problems are linked to the strategy of stepped care, which is really a wait and see. Let's try something, wait and see if that works. And if it doesn't work, we'll think about something else. And if that doesn't work, we'll, and so on. And that, to me, that's what leads to delays. There's a lack of initial comprehensive BPS means biopsychosocial assessment. That's an assessment of the whole person rather than just the injury. And there's no shared care plan between providers and the workplace in general. So that's the GP, the physiotherapist, and the workplace and their insurer. All those players or stakeholders seem to hardly talk to each other. Now, Professor Ian Cameron, also from the Collins, and part of this presentation, was asked by CIRA, the regulatory authority in New South Wales, to review various aspects of rehabilitation and care under our current system. And he and his colleagues reported in 2020 on pain management for workers' comp cases. And what they identified, that research to 2013 indicated the importance of psychosocial factors in delayed recovery. And they noted that failure to identify these psychosocial factors could increase the risk, not just of psychological injury claims, but also poor return to work outcomes. Now, in 2011, I'd been doing some research in Sweden with Professor Stephen Linton as a visiting scholar, and we revised a scale that he had previously developed to a 10-item scale intended to identify psychosocial risk factors for delayed recovery. And we published this in the journal Spine. It's 10 items. It includes measures of severity of pain, distress, that covers anxiety and depressed feelings, disturbed sleep, expectations of delayed recovery, and beliefs that pain should guide activities. And that was quite effective in identifying at-risk cases in Sweden, but we needed to demonstrate that it would work in Australia. So I came back and been using it ever since. And the question here is, does it identify those likely to have delayed recovery in this case, New South Wales? So since 2013, there have been a number of studies, two I've mentioned now. One is by Ian Cameron's group, which I was part of as well, published as part of a PhD by Gopinath et al. With motor vehicle accident cases, again confirm the value of the scale in predicting people who would have trouble being back at work within a year and other poor health outcomes. A second study was published by myself with a group I've been working with workers' compensation cases, in this case using New South Wales Health's injured workers. And what we found is the instrument can be read out over the phone by an insurance claim manager to an injured worker. When it was done within 15 days of the injury, we could identify high-risk cases. What I was interested in is that none of these cases we identified had been referred for more comprehensive assessment. So they were being missed by the people in charge of overseeing care for injured workers. And this is what the data looked like. This was the paper we published in 2018. And you'll see the high-risk cases over a 2-year period took far more time off than low-risk cases from very similar injuries. There was no difference really in the nature of their injuries, but there was in their psychosocial risk factors. And you can see that this measure could actually identify between the two groups or discriminate between the two groups quite easily. Of course, none of this is really new. People have been trying early interventions for psychosocial factors for some time. This was a study done in the Netherlands. But what they found is that while they tried dealing with psychosocial factors in that early stage with people with subacute low back pain, they had no effect. But when you look closely at what they did, what I noticed is they did not select high-risk cases. They just gave the psychosocial advice, that is to keep moving, don't worry about pain and so on. They gave that to everyone, whether they needed the advice or not. So they didn't select those at risk. So I think selection of these high-risk cases seems important, because you've got to remember most people actually recover quite smoothly from an injury, and they're not a problem. But the ones who don't are the problem. But selection is not enough. Just identifying those at risk is part of the job, but then what do you do now? Now, there's been a huge trial just published in the United States where they used an approach developed in the UK at Keele University called stratified care, where they used another screening measure called the start back for people with back pain. with acute back pain in this case, and identified the high-risk cases. And they trained physiotherapists to give what they call psychologically informed physiotherapy, which is about education and overcoming fears of movement and so on, and compared those to controls getting usual care. However, the outcomes, again, there's no difference in disability or chronic pain between the two groups. Opioid prescribing and imaging prescribing were the same, although both actually were non-concordant with clinical guidelines. So again, another failure. Now, why is that? Well, I believe from looking at the paper, there was a failure to coordinate the treatments between the physiotherapists and the doctors. And that meant the treatment was not matched to the patient's problems. So to me, it was a question of their implementation and design of their study. My colleagues, Stephen Linton from Sweden and Bill Shaw from the United States, and I published a commentary about this issue in the journal Pain in 2018. And we said there that it's not just any early intervention, but rather any intervention must be coordinated and target the risk factors. So we have been doing this with New South Wales workers, New South Wales Health's injured workers, in a study we called the WISE study, which is Work Injury Screen Early study. And we published this in the Journal of Occupational Rehabilitation last year. And we dealt with injured New South Wales health workers. So people who work in the hospitals, not patients coming to the hospitals. They were identified as high risk within 15 days of their injury. And then they were, if they agreed, they could see a psychologist who would assess what the problem was and then address that problem. And so they matched the intervention to the presenting problems. The screening instrument identified who was at risk, but then the psychologist had to identify what was the problem with this person. And this intervention was coordinated with the medical, that's the GP, the physiotherapy, and workplace interventions. And we got the results you can see on the screen. For the control group who got usual care over a 2-year period, they had a significantly higher number of lost days compared to the intervention group on the right in the dark group. This study has attracted a lot of attention. ICARE actually gave us an award for excellence in 2016 for our study, and those are my key colleagues. I'm in the red shirt in the middle, and on my left there is Gary Pearce, who's a rehabilitation physician, and very sadly, he died the following year. And he was doing his PhD on this, and this is in recognition of his contribution today, I would have to say. And on my right is Mick Gleason, who is a physiotherapist who was our manager. And then just recently, we were awarded by the Journal of Occupational Rehabilitation this award of the best paper published in that journal in 2020. So it's had international recognition, but we've carried on from that study, and now we've been completing another study, a replication, if you like, of that WISE protocol of injured Australia Post workers. It's called an MCAP, Early Matched Care at Australia Post. And this is getting almost identical results to the WISE study. And on the left there, highlighted, you see the risk score goes down to below the cutoff. So that means after the intervention by again, the psychologists, combined with the other healthcare providers, these injured workers were no longer at risk of delayed recovery. And in fact, already the recruitment is finished, and we're in the follow-up phase. But again, on average, 5 sessions by the psychologist was sufficient, the same as in the WISE. And the return to work rate so far, and almost 1.5 years, is half the time of the treatment as usual group. It's too early to talk about the final results, but that'll be next year. But already the federal government's workers' comp insurer, Comcare, has recognised the value of our project, and we've won this award for recovery at and return to work, which was announced just a few months ago. And excuse
me,
yeah.
Michael, you just got 30 more seconds, please.
Okay, so and I'll leave it there, but the final summary is in injured workers, psychological and social risk factors are present from day one. You can identify them with screening, and if you target them, you'll get better results. Usual care risks delays in these people, but all must play a role. Success requires these contributors to be coordinated, but implementation at a system level remains elusive. Thank you.